Assalamu alaikum, everyone. Thank you for being here today for the lecture series. Dr. Nabeel will be conducting a lecture on daycare, daycare surgery, on laparoscopic surgeries. And Dr. Nabeel he did his FCPS from Khan University Hospital in 2006. And then he did his fellowship in cardiac anesthesia, and he did his EDIC in 2016. Currently, he's a consultant anesthetist since 2015 at the University Hospital of Leicester. I welcome you, sir, and thank you so much for being on board with us. You may please start the session.
Okay, thank you very much for giving me the opportunity to just present some guidelines in related to the daycare laparoscopic surgery and some evidence-based practice. So I will discuss in this 1 hour. I'm just going to discuss you about the pros and cons of the daycare laparoscopic surgery and what are the new advances in daycare surgery and the criteria for daycare procedure. Initially, there was a myth that most of the cases can be done as an inpatient. We normally hesitate to discharge patient back home and thinking of might be any complication happen. But the criteria since in the last couple of decades, the criteria has completely changed. The cases which we used to defer it as an inpatient, or we used to do it as we were a bit reluctant to do it as an daycare procedures, has now been the absolute indication for doing those cases in as a daycare procedure. And what they have they found out that the cases which can be done as a day case improve the patient safety, and it reduces the morbidity and mortality of the patients. So I'll just go through in the literature through some of the guidelines, and then I'll give you some evidence based recently. First of all, I'll just give you a bit update about myself. I'm Dr. Nabeel Sultan. I'm just working. I've done my FCPS from anesthesiology from Khan University Hospital in 2006, and then I was being promoted as a senior instructor over there. I worked as a senior instructor for a year and then moved to Saudi to do the cardiac anesthesia. So I did adult and pediatric cardiac anesthesia for 2.5 years. Then I moved to UK in 2010. And then I did all my work to get myself certified as a consultant anesthetist. And I did EDAC, which is the European Diploma of Anesthesia and Intensive Care in 2016. And I got the consultant anesthetist job in 2015 in University Hospital of Leicester, which you can see on the screen. And since then, I'm still in Leicester. Since then, I'm still in University Hospital of Leicester. My current responsibilities are at the moment, I was the renal transplant anesthetic lead, and I started the high risk clinic for the renal transplant patients and do optimization for the patients, and being part of the MDT. So we screen the patients and do the renal transplant. So I've been doing this for 8 years as a renal transplant anesthetic lead. Apart
Nabeel,
from I think somebody needs to turn himself mute so that we don't have any interruption in between. So as an anesthetic lead, this is my one way of one responsibility. The other responsibility was I was the audit lead at the University Hospital of Leicester, and being responsible for conducting the audits and quality assurance. And so now I'm doing I have a special interest in awake fiber optic intubations and awake blocks for the orthopedic surgery for the upper limb and the lower limb surgeries. That's what is my main interest, and I'm at the moment being part of the team who is doing the awake blocks for the upper limb and lower limb surgeries. Okay, now this is the University Hospital of Leicester. We have got 3 hospitals joined in one trust. The one which you can see on the screen is the Leicester Royal Infirmary. The other one is Leicester General Hospital, and the other one is Glenfield Hospital, which is mainly does the cardiothoracic and cardiothoracic surgery. But I mainly based at Leicester General Hospital, where we do the adults. Normally we do the specialties like urology, orthopedics, gynae, and major gynae surgeries, cancer surgeries. We do robotic surgeries here as well. Okay, that's a brief introduction for myself. I won't waste your time, guys, and then started my presentation about the day case surgery. I'm sure you all guys know the definition for the day surgery. I mean, this is what in Great Britain and Ireland we call it when the patient been admitted on the day and can be discharged on the same day with the intended management. It's called the day case surgery here. But the recent drive since 2000, there are certain organizations like GERFT getting it right first, and so they made their recommendations, and they want to do around 50 to 70% of their normal surgeries as a day case surgery. So the recent drive is basically to reduce the length of the stay. I don't know whether you guys are aware, because we have got a burden on NHS. There been patient been waiting for 3 to 5 years for their operation to be done. Hence, the drive was driven to do most of the cases which can be done safely as an elective procedures, so that they can be discharged on the same day, and it reduces their length of stay, reduces the bed consumption, and obviously it helps patient mobilize on the same day, and reduces the chances of morbidity and mortality. Daycare surgery brings about the benefits which I just mentioned to you, that reduces waiting time and a release of valuable beds, which are really of a concern at the moment in NHS, because we are very limited in our bed situation, and because of the bed situation, patient has to wait for 3 to 5 years. So the daycare surgery bring the benefit of being discharged on the same day and reduces the waiting times. So the GERFT, as I mentioned here in 2020 in September, motivated all the NHS trusts to do at least 70 to 75% of their surgeries as a day case procedure. So the background is for the day case procedure. I mean, it's been happening for a very long time, and I'm sure it's been happening all over Pakistan, all over the world as well. But I'm not aware of how much the percentage of the day case surgery has been happening in Pakistan, because in the government sector it's completely working differently compared to the private sector. But in UK, the use of day case surgery has been increasing since 2019, and around 66%, as I said, around 70 to the aim was to go up to 70 to 75%, but around 66% of the surgical admissions within NHS England as are being taken as a day case procedure by GERFT, which is the organization who published their report and who made the drive for the cases to be done as a day case procedures. So laparoscopy, we all know, is been there since 1960s, obviously, but obviously because it was a novel technique at that time, there wasn't much skills available. But with a period of time, the skills of the laparoscopy has been improved quite a lot, and the laparoscopic surgery has gained an importance and gained a significant significance in the general surgery and in the world of medicine. Since the 1970s, there has been a dramatic increase in the number of the procedures that are carried out as a day case procedures, so much as across, as I said, mentioned before, that around 80% of the surgical procedures has been done laparoscopically. And this has been published by Anesthesiology in 2011, and the guideline for the provision of anesthesia care services. And in London, Royal College of Anesthetists have the guidelines that around 80% of the surgeries have been done laparoscopically. So laparoscopic surgery, as we all know, I will not go into the details of what laparoscopic surgery is and how do you do laparoscopy, but I'll just give you the brief outline that the procedure, it is the gold standard procedure for most of the gynae procedures and the general surgery procedures and colorectal procedures, and specifically for minor gynecological surgeries. But now there is a new advance in of the laparoscopy, which is called the robotic surgeries, and now robotic surgeries are taking over most of the laparoscopic work. And it's just because, like comparing laparoscopic surgery, if you compare with the open surgery, it's less invasive. Incision was very small, and the pain was very less compared to the open surgery. Patient being mobilized very quickly, and less chances of complication. So laparoscopy techniques offer obviously the more benefits, because there is a shorter recovery state, and this plays a vital part in the day case surgeries, because most of the day case surgery like laparoscopic cholecystectomies, laparoscopic hernia repair, or like as I mentioned, the gynecological surgeries, laparoscopy treatment for endometriosis, and hysteroscopy, all these procedures can be done laparoscopically safely as a day case procedure, and that's why it gained so much popularity. National Patient Safety Agency, which is another organization of the UK, and which submits their report, and they said that in around in a 7-year period of time, and they just mentioned their report that around only 48 serious incidents happened in 7-year period, and there were 11 deaths happened because of laparoscopic surgery. So now I'll just come to the criteria for day case surgery. So I divided the criteria for day case surgery into 5 different subclasses. Obviously, you need to have a proper setup in order to do safely the day case surgery. First of all, obviously, you need to do a selection of the patient. Not every patient will qualify for the day case surgery. You need to have a robust team who can screen the patient, and then carefully selecting the patient for day case surgery. Uh, in selecting the patient, there are certain factors which you need to keep it in mind. I'll come on the other points later on. First of all, I'll briefly explain you how what factors you need to keep it in mind in order to do the selection of the patient. So in order to do the selection of the patient, there again is being divided into 3 subcategories, which are called as social, medical, and surgical. So the social categories are obviously not every patient will have the support so that he can come and go home safely on the same day. But you need to make sure that when you are selecting the patient have a social setup, like somebody can escort the patient to the hospital and can take him back home, and been looking after the patient for the first 24 hours. We normally recommend that at least somebody will be at home for 24 to for the first 24 hours in case of any emergency or any need happen, but not I mean, this was the criteria initially, but not all the cases do require 24-hour support from a carer point of view, like especially if the patient is having a minor procedure like incision and drainage as a day case procedure, or a hysteroscopy gynecological procedure, then they don't normally require a 24-hour support. But obviously for a laparoscopic surgery like laparoscopic cholecystectomy, or other laparoscopic treatment of endometriosis, or laparoscopic inguinal hernia repair, so they might need somebody to be with them for the first 24 hours. And normally we instruct the patient not to drive any motor vehicle for the first 24 to 48 hours. So these are the things which you need to keep it in mind in selecting the patient in terms of their social factors. Obviously, the social factors is different in Pakistan compared to UK, but this is generally you need to keep it in mind that these factors should be ideally being addressed before selecting the patient for the day case procedures. Next one is medical condition. Obviously, we normally what we said that patient should be patient should be assessed not by their physical status but by their physiological status. Normally, we said if a patient is ASA3 but his diseases are quite controlled, so then he can still qualify as a day case patient. So patient should be assessed should be assessed at the preoperative assessment clinic as a functional status, not by their ASA status. Sometimes patient is diabetic, ischemic heart disease, but they are very well controlled, and patient do a good exercise, do have a good exercise tolerance, and they have a good physiological status. So then they can still qualify for the day case surgery. But any patient whose medical condition is not very well controlled, like as I said, diabetes is not controlled, hemoglobin A1C is more than 8.5. Normally in NHS UK, the normal criteria for doing any elective procedure is hemoglobin A1C should not be more than 9. So if the hemoglobin A1C is more than 9, then obviously you need to you don't select that patient as a day case procedure, and he needs to be optimized before his procedure, or can be done as an inpatient in order to control the medical disease. Again, and then it comes to the third factor, which I just mentioned, is the surgical factors. In order to select the patient for a day case surgery or a day case laparoscopic surgery, the surgery plays a very important role. The procedure should not carry any serious post-operative medical complications, any post-operative complications like hemorrhage or any cardiac ischemia or any cardiovascular complication. So not all the surgeries qualify for the day case procedures. It should be assessed carefully that this procedure does not carry a significant risk of any post-operative complications. So these are the three important things which you need to keep it in mind before selecting the patients for the day case procedures. The other things which, as I mentioned in my previous slide, is that selection of the patient. Now, in the social factors, obviously, you need to assess the age of the patient. And as I mentioned before, that there should be somebody who can escort the patient at home and will be looking after the patient for the first 24 hours. And the patient should have a clear communication, should have a clear instructions in hand when he come to assess, come for a pre-assessment, and he should be explained briefly what he needs to expect, and how when he go home what he needs to do, and in case of emergency he should be having the contact numbers of the hospital, or where to contact. And if he has got any disability, if he's using wheelchair, if he's using frame, so that needs to be explained at the time of pre-assessment. The medical factors which I just mentioned, that any controlled disease, any controlled medical conditions can be done easily and safely as a day case patient. There were certain contraindications which we used to think before, that somebody who has got a obesity is a contraindication for doing as a day case procedure, but obesity is no more a contraindication for doing the day case procedure. Even obstructive sleep apnea is not an absolute contraindication, and sometimes patients do better doing as a day case procedure for the obstructive sleep apnea or obesity patient, because their normal routine doesn't interrupt, and they will have a short procedure, and then they can be mobilized early, and they can go home. And what we recommend normally here, our normal practice is, any patient who has an obstructive sleep apnea and having a nasal CPAP, we ask the patient to bring it to the hospital, and after that when we discharge them, so they can go home with the nasal CPAP. Okay, and the surgical factors, obviously the procedure, as I said, that should not carry a post-operative risk of complications. And so the most important complications normally as a day case post-operatively in the recovery area are nausea, vomiting, and pain. That should be controlled. But as a day case procedure, we don't normally recommend that the use of opioids like morphine, but the long-acting non-steroidal NSAIDs can be used, and along with the simple analgesic, but a multimodal analgesia should be recommended for a day case procedures. It's always been a combination of the analgesia and preemptively given the antiemetics to help them with the with nausea, vomiting after the surgery. What is really important is a multimodal. I said the multimodal analgesia. Multimodal analgesia includes obviously the oral paracetamol or oral acetaminophen and NSAIDs, long-acting NSAIDs, and if you can give some local anesthetic as well to help insufflate the area to give some nerve blocks. So this is called the multimodal analgesia that will help improve the patient outcome, improve the patient early mobilization and discharge. So any patient, any procedure that can be done should not prohibit the patient to resume oral. I mean, what we recommend normally after the day case procedure, if it is a 1 hour or 2 hour procedure, patient should offer some drink and should be able to at least to have some liquid diet, soup or a drink, tea or coffee. And once they resume their oral intake and they've been feeling fine, then obviously that can fulfill the criteria for their discharge. We normally recommend to mobilize these patients early after the surgery. Obviously, if they are pain-free, if they don't have any nausea or vomiting, they should be mobilized early in order to have a safe discharge from the hospital. And if the patient started taking their oral fluids early, they normally go to the loo and then they can pass urine. If they can pass urine, and then they can safely fulfill the criteria for discharge. But appropriate venous thromboembolic prophylaxis should be instituted depending on the type of the surgery, length of the surgery, and the comorbidities. Like if the patient is obese and been immobilized for 3 to 4 hours, then venous thromboprophylaxis should be instituted before the discharge, and the clear plan should be given to the patient, and some anticoagulant plan or deltaparin or Claxane should be given to the patient for the next 3 to 4 days, depending on what the policy of the hospital is. Okay, now it comes to the anesthetic management. So the national guidelines, any patient who can come for a day case surgery, we have got a national guideline for the patient monitoring, in which baseline monitoring like ECG, saturation, and end-tidal carbon dioxide and blood pressure monitoring is the basic monitoring, which should be attached for every patient, irrespective of coming for a day case or an inpatient. So as I mentioned in my previous slide, that analgesia is of paramount importance. Obviously, if the patient is pain-free, and then they are more likely to be discharged early. And but as I said that we normally try to avoid the indiscriminate use of opioids. Short-acting opioids like fentanyl can be used, say, safely for the induction of anesthesia and during the maintenance, but long-acting opioids like morphine should be discouraged. Prophylactic antibiotic, this is a normal routine here. We normally give a prophylactic antibiotic for all of our patients to prevent nausea and vomiting post-operatively. The routine use of intravenous fluid, if the patients are nicely hydrated, we don't recommend to overhydrate the patient, but we normally recommend to keep the patients being hydrated, so that can maintain their body temperature and enhance the patient's feeling of well-being, and that will reduce the further post-op nausea, vomiting, and they can be discharged home safely on the same day. So there is some evidence which I just want to share with you guys. Is this was being published in 2016 as a day case laparoscopic surgery patients. What they have done in UK, they compare the different uh, they compare different BMI, because as I mentioned earlier before, this was an contraindication which is no more now, that people thinks that the high BMI patients cannot be done safely as a day case procedure. But this was done. This study was published in Annals of College of Surgeons England in 2016 May, and they compare three BMIs, 25 to 29, and then The other one is between 20. The first group, they compare the patient with a BMI of 25. The other one is 25 to 29, which are obviously more obese patients. And the third group is between 30 to 39 kilogram per meter square BMI, which is morbidly obese patient. And surprisingly, they didn't find that there was a difference in the BMI in on the success rate of the patient. The overall success rate for the day case surgery was 78%. Most of the patients have been discharged. There were around 571 patients. They all have been discharged on the same day. And what they have noticed, only the high BMI, the morbidly obese patients, the only thing is they find that the duration of the procedure was a bit longer, like 55 minutes duration compared to 46 minutes to the other BMI patients. So the overall success rate for these patients were 80%, around 80%, and there were no signs of recollection or retained stones or abdominal connection in any of the BMI patient. So this clearly indicates that that day case laparoscopic surgery, even for a high BMI patient, can be safely done. Can be safely done with precautions, and obviously depending on the of your hospital guidelines and the practice. So the other study which showed the outcomes of laparoscopic colorectal surgery in obese and compared to non-obese. So again, they compared the high BMI to the low BMI patients, and laparoscopic surgery, but for the colorectal surgery, and match study of 180 patients, and they didn't find any difference at all among the two groups. Although they find in obese patients to do the laparoscopic surgery is more convenient because they have got more room to operate, and it's quite easy to operate in a laparoscopic surgery compared to an open surgery where there is no pneumoperitoneum. Okay, so again, there is another study which says safety consideration. So what World Journal of Gastrointestinal and Endoscopy is, this was published in 2022. It was a narrative review, and what they made the recommendations for the safety considerations in laparoscopic surgery. They made certain recommendation, and then they said that how can you perform the laparoscopic surgery safely, what precautions you need to take. And what they did, they made certain recommendations, that like the positioning of the patient. Sometimes you need to do extreme steep position, steep head down, for mainly for the gynecological procedures. And so they recommend that the position should not be very steep. Even for laparoscopic cholecystectomy, you need to do head up and rightward tilt. So that obviously helps against the regurgitation. They said to use the different ports, for the surgeons to use the 15 millimeter port instead of the 20 millimeter port, because that can cause less pain to the patient. And what they said, that intra-abdominal pneumoperitoneum, you can use the intra-abdominal pressure around between less than 12 millimeters of mercury. So that will help reducing the help in reducing the cardiovascular compromise. And obviously they recommend to use the antiemetics prophylactically. And what they did, and they recommend to use the local anesthetic infiltration for all the surgical patients in order to reduce the pain, after the surgery, hence early discharge from the hospital. So these are the few evidence-based practices which has been published recently in the last around 6 to 8 years, and they clearly indicate that the surgery, laparoscopic surgery or day case surgery, can easily be done even in the obese patients, even in obstructive sleep apnea patient, with specific measures with certain precautions. So now I just want to give you a brief overview about the regional anesthesia as well. I mean, compared to the laparoscopic day case surgery, regional anesthesia can also be used. As I said, excuse me. As I said, that a local anesthetic infiltration along with the nerve blocks can provide excellent anesthesia and pain relief after the surgery. You can use local anesthetic infiltration for any laparoscopic surgery, for as I said, for inguinal hernia repair, for gynae surgeries, for laparoscopic cholecystectomy, and so this can give you effective pain relief, and and the patient can be discharged home after the surgery. And for a shorter procedure, you can still use the regional anesthesia techniques like spinal. What There is a normal practice. I mean, in most of the trusts in UK now, they started to have the block room where they normally do the nerve blocks for most of the patients, for day case patients, and so the patient will have some time. Before they go into the theater, where you can safely check the adequacy of the nerve block, and the patient, even after the day case surgery with a nerve block, patient can safely be discharged home. And spinal, if you really need to give the spinal anesthesia can also be given. And we have been using here hyperbaric prilocaine or 2% chloroprocaine. So hyperbaric prilocaine 2% normally gives you an anesthesia, a spinal block for 1 minute, 40 minutes to an hour. And this is more than enough for a surgery for 40 minutes procedure. And then after that, patient we will recover from their spinal anesthetic, and easily, safely can be discharged home after the day case procedure, especially for foot surgeries, for big toe surgeries, and for bunion removal. So you can use this hyperbaric prilocaine for a shorter procedure between 40 to 60 minutes. But what is really important, and I do stress again, as before I told you that multimodal analgesia is really important. An analgesic plan should be in place. Even if you give a spinal anesthetic or you give the local nerve block, there should be an anesthetic plan in place, because obviously your spinal anesthetic will wear off shortly, in 1 hour, 1.5 hours. Or even if you give the nerve block will wear off. Then after that, patient will started feeling pain. So you should have a proper plan, and you should start giving the pain relief before the local anesthetic effect will wear off. The normal practice in our trust is after even giving the spinal, we always give the patient a paracetamol, and if we are giving non-steroidal, longer acting non-steroidal, we always give them before the local anesthetic wears off. And then we give the patient a longer acting an analgesic plan to take home. Pre-medication with oral analgesic, as I mentioned, we always give, this is our routine practice, we always give to the patient, and the patient can take longer acting non-steroidals and other pain medications to take home once before the local anesthetic will wear off. So as I mentioned, laparoscopic day case procedures, these are the specialties in which laparoscopic day case procedure can easily be done. Gynecological surgery, as I mentioned before, general surgery, orthopedic, pediatrics, and ENT circumcisions can be done as a day case procedure with some very good effective pain relief by giving them penile blocks that will work for around 24 hours. So ENT procedure, small minor ENT procedure, DNS, DNS, and grommet insertions. All these procedures can be done as a day case procedure. But as I said, there should be it's a multidisciplinary team effort, where you need to have a proper pre-assessment clinic, where you need to see the patient preoperatively, assess the patient preoperatively, and then selecting the patient appropriately that are suitable for the day case procedures. And then after that, you plan your anesthetic according to the procedure. Do your anesthetic, give good analgesia, whatever is required, either regional anesthesia or spinal anesthesia or general anesthesia. And then your patient should be able to go back home safely. So after that anesthetic management, once you do the block and the patient being discharged to the recovery, then post-operative recovery and discharge. What I what I did, I think there were 3 stages of the post-operative recovery and the discharge. First stage recovery, and the second stage recovery, and the third stage recovery. So in the first stage recovery is when you shift the patient to the recovery, when the patient is not fully awake, but he can maintain his cuff reflex and gag reflex, and his reflexes are back, and his vital signs and monitoring is all been within normal limits. So that's the first stage of recovery, where you send the patient to the recovery. And at that time, the patient should not be in pain. The recent guidance for driving, normally, I don't know whether you still use isoflurane over there, but we don't normally use isoflurane. We use sevoflurane here in UK. So, but for the recommendation for the isoflurane is not to drive for at least 4 days after the use of isoflurane anesthetic. And then, as I said, the first stage of recovery is when you shift the patient from the theater to the recovery, and where the patient reflexes are back, and he is not in any pain. The second stage of recovery is when the patient steps off the trolley. He is awake enough, he can stand, he doesn't feel dizzy, and he steps off the trolley. And when the patient is ready for discharge from the hospital. So when you assess the patient, as I mentioned in my previous slides as well, that patient should be able to pass urine before being discharged. He'll be able to drink tea or coffee or whatever it is, at least, and he's not feeling dizzy. He's not feeling any nausea or vomiting, and he'll be able to step off the trolley. So then this is the time when the patient is ready to be discharged. There is a late phase when it's called the late recovery, and this ends when the patient made a full physiologic and psychological recovery that will take around 4 to 5 weeks. So that's called the late discharge or late recovery. That's when ends. But all the patients should be discharged with instructions and with appropriate care. And as I mentioned, that they should go with somebody who will be looking after them for at least for the first 24 hours. Then normally in Pakistan, we do have a bit of a support from the family. So somebody should be with the patient, husband or wife, or maybe parents, if their kids have been operated. So, but clear instructions should be given to them in case of any emergency, or where to go and how to contact. The contact number should be in the written instruction sheet. So the take home message for my presentation is, like, around 70 to 80% of the procedures can easily be and safely being performed as a day case procedures. As I mentioned, and I gave you a brief overview of most of the medical conditions which are being controlled, can easily and safely be done as a day case procedure. Thorough anesthetic-led nurse delivered pre-anesthetic assessment. I mean, we have got a pre-assessment here being led by the nurses. They normally have the questionnaire. They ask the questions, and they will order the baseline investigations. And if so, that's first part of the preparation as part of the day case procedure, and as well as protocol driven discharge. So there should be a protocol driven discharge by the hospital, so everybody will follow the protocol in order to deliver the safe and effective day case surgery. Fitness for a procedure, again, as I mentioned before, should not correlate with the ASA status. It should be assessed by the physiological status of the patient. If the patient is either having ischemic heart disease, but he exercise around 4 to 6 mats a day, he can climb 2 flights of stairs, then he should be assessed on the basis of his physiological status rather than ASA physical status. All the anesthetists who are performing the anesthetic should be aware of the should be familiar with the anesthetic technique, should be familiar with the protocols in that hospital, and the discharge criteria in order to enable the patient for early discharge. If the anesthetist is giving early block, a neuraxial block, he should be aware of what the procedure is and what local anesthetic you need to use, either the longer acting or the shorter acting. We can still discharge the patient after the nerve block, even if they have got a residual sensory or motor blockade. But if they have been accompanied with somebody, so you can still safely discharge these patients after the nerve block if they still have some remnants of the sensory or motor blockade. And again, the quality assurance and improvement programs are obviously, we always recommend that, and this is the normal practice here. Whenever we made the protocols, we always revisit them and assess them again for any improvements, and we do the audits to see how our guidelines are going on, and if there is any room in improvements or any room in changes, so then we can do. So this is the part of safety and improvement as well. Always do the quality assurance and audits of the practice what you are doing, and on the basis of that you can make the guidelines so that to perform a safe surgery for the patients. I think that's all from my side, and I hope this will give you a brief insight of about the day case surgeries, and if anybody wants to ask any questions, or so you can.
Assalamu alaikum and a very good evening, Dr. Nabeel. Azhar here.
Okay, walaikum assalam, Azhar, how are you?
I'm fine, I'm doing good. Thanks a lot for such a brief and informative talk regarding the anesthesia concerns in the surgical daycare procedures. So we have a couple of questions. The first question is by Dr. Nadir Adil. He just want to ask if use isoflurane, why it is recommended to drive after 4 days.
Yes. Because you know that the excretion through the liver is around 6 to 7%. It will be metabolized in the liver, so that's why, because it takes longer to clear from your by the liver to clear it out. That's why it's recommended that you cannot drive for 4 days. But as I said, that isoflurane, we hardly use it. I don't know what is the practice over there in Pakistan at the moment, but we hardly use isoflurane here. We normally use sevoflurane, and this is not the recommendation for sevoflurane.
Yeah, here in Pakistan, isoflurane is extensively used. We do
All
use in
right.
the daycare procedures,
Okay.
and most of the time we discharge the patient within 24 hours.
All right. It's
Um,
just only because of the metabolism in the liver. That's why they don't recommend. And you know this here in UK, because the laws are so strict. If you can't instruct the patient not to drive for 4 hours for 4 days, sorry, and if they drive after 2 days and they had an accident, then obviously they can sue the trust. So that's why we are very cautious in giving the instructions to the patients, and to make sure that once they started driving, they are quite safe.
okay, so Dr. Syed Zishan Javed Hashmi has a query. You can unmute yourself, and you can ask the question.
Yes, Assalamu
Doc-
alaikum, sir. It's really
Walaikum
nice to
salam.
hear from you. This is Dr. Zishan from Riyadh. Actually, I have a small question. I'm working in a military setup, and we do a lot of day surgeries. There was a query about the duration of surgery. Is there any specific? Maybe I joined late, so I'm not sure whether you mentioned about this thing or not. With reference to the duration of the surgery, is there any strict recommendation that that much hours is a cut limit? Or because sometimes they start the surgery, and in our hospital sometimes they are, even for dental procedure, they are taking 3 to 4 hours even. So is there any recommendation from NHS with reference to hours of the surgery? This is
Yes.
one question, and I have another question. After you answer, I will ask another question.
Yeah. This is a very good question. Normally, people do think that there is a limitation of like 2 hour surgery, only you can do it in a day case procedure. There is no such recommendation from the NHS that the surgery should be limited to 2 hours. I mean, it cannot be like 8 hour operation, obviously, but between 2 to 4 hours. But it all depends the type of the surgery. If the patient having major blood loss during the operation, then obviously that patient is not suitable for to be done as a day case procedure. But any surgery which is clean can be, and if it fresh in 3 to 4 hours, that can still be safely discharged, still be safely done as a day case procedure. But again, it depends, as I mentioned in my previous slide, the selection of the patient is really important. But again, duration is not, I mean, there is no such guideline that only you can do like a 6 hour operation you can't do as a day case procedure. But obviously, normally most of our day case procedures are between 2 to 4 hours.
Okay. Okay, fine, fair enough. And there is another question is with reference to like a pediatric, like is there any limit for the body weight Like for example, sometimes circumcision babies, they are uh, like quite low in weight. Maybe they are term, but still low body weight. So is there any relation with the low body weight?
There is no relation with the low body weight. There is a relation with the preterm deliveries. If the preterm baby, obviously, I don't know, the practice in Saudi is at which age they want to do the circumcision. If they can do it as a newborn, so obviously they are normally in the hospital after 7 days. Normally after, like, so after circumcision, they normally discharge the patient home. But there is a limitation for the preterm babies, not the low birth weight babies.
Okay, sir. Just one more question with reference to inhalational anesthesia versus TIVA. Are you people having some guidelines that, or you are like recommending surgeries under
Yes,
TIVA with
yes, there
reference,
is a
because there will
huge.
be so much advantages. TIVA and also opioid-free anesthesia.
Yes, there is a huge drive in UK now towards the TIVA. In our whole, in my trust as well. I mean, everybody is driving towards TIVA. They're moving away from the inhalational anesthetic and opioid-free anesthetic. We normally, for any regional block, we don't use any opioid. And normally for most of the surgeries, especially for the longer, like robotic surgeries, which normally last for around 4 to 6 hours, colorectal surgery, we run TIVA. We don't use inhalational anesthetics.
Thank you, sir. Really appreciate it. Thank you.
Welcome.
Thank you, Dr. Zishan. Dr. Zishan is very pro in educating our residents and consultants as well. Very often he shared the informative links and books with us. Thank you, Dr. Zishan. So there is another question by Dr. Nasir. He just want to ask regarding the readmission of daycare patient with pain in emergency in your setup.
Yes. I mean, as I mentioned before, that this is really important, that you need to have it's a multidisciplinary setup. So where you need to, the hospital should have a plan to how to do the daycare surgeries and how to control the pain. There should be a protocol driven thing, that what analgesia you need to use. But in case, obviously, if the patient is in severe pain, what we normally ask the patient, we give them the numbers through which they can call the pain nurses. If their pain can be settled on the phone, they can give them advice on the phone. If not, then they have to come to the A&E to have a further checkup. If maybe there is some bleeding or any other complication is happening, then they have to attend the A&E.
So roughly how frequent is it
Very rare, very rare,
in terms of, okay, oh, okay,
very
that's
rare.
great.
The
So
only thing which we have noticed is sometimes, like even for the lab colleagues, we were unable to discharge them on the same day, so they might have to stay overnight. Then, but they can be discharged safely on the next day. That's the only thing. We never discharge the patients if they are in pain or if they have got any symptom. But we have very rarely seen patients going home and then they came back because of pain or nausea or vomiting.
okay, thank you. Dr. Shahid Rasool has a question. He just want to ask the role of dexmedetomidine, the practice in your setup.
Okay, so dexmedetomidine is normally we don't use it as a day case procedure. This can be this some of our units. I mean, we don't use in our trust, but in some of the UK hospitals, it has been used in the ITU setup only. But we don't use it as a day case procedure.
Okay, so it's because of the sedation that it
Yes,
causes.
yes,
Okay, another question is by Dr. Fan. He is interested to know the prehabilitation of the patients. He just want to ask the role of uh, carbohydrate containing fluid, just like we do in
yes,
the enhanced recovery patients.
yes,
So
yes.
is it in your practice, in your setup?
Yes, yes, this is a very good question, and I think I forgot to mention that one, that we always have a carbohydrate solution which is called the pre-operative drinks. We give normally when the patient will come for the pre-assessment to have a pre-assessment. So we normally give them two drinks. The first drink they have to drink it at the midnight, and the other drink when they are coming to the hospital. So they have to take the early morning drink at around 6 o'clock in the morning. So they do normally have those two drinks before on the day of the operation.
Okay, Dr. Sayed Zishan has a question. Dr. Zishan, you can ask your question.
Yes, I am really sorry to interrupt because I am a big lover of Presidex, and I will just have a small comment with reference that a number of people who are afraid of its sedation or delayed recovery, actually they are trying to use the same dose which is documented or researched more for ICU patients, where the dose is relatively more. Okay, but if we are using in combination of other medications, we definitely have to give a very smaller dose, very small dose, because if you are giving high dose, then definitely it will delay the recovery. But if we are using it in a small dose, it's a wonderful medication, because rather it will be better because it will not have the side effects which the opiates, if you are giving in other side you are giving opiates. So opioids will actually cause more side effects with reference to nausea, vomiting, and with reference to respiratory depression as compared to Presidex, because Presidex only creates problem if you are giving in a higher dose. This is, I just wanted to comment with reference to the
Is this
dexmedetomidine.
Presidex is a dexmedetomidine?
Yes,
Yeah.
because the dose which is like if they are if they are using a dose of the concept of loading dose and then an infusion or things like that, then it creates a big problem. Yes, but if you
Actually,
are using, yes.
yeah, actually, there are 2 points in practicing in UK, because being an NHS, it's been driven by whatever is available. So the NHS has not funded this for the day case procedures. And the other thing is, in when I was doing research, I mean, I was looking at the different guidelines from the different hospital across the UK. So there nobody has mentioned any role for the day case surgery at the moment. It might come in later. I'm not sure, but at the moment nobody is, at least in UK, is using it as a day case surgery.
Okay. Nadir, you have written a question, but I am unable to understand. If you can unmute, you can ask your question directly. Meanwhile, Dr. Khalid Shah has a question. He just want to ask about the what's your preference for spinal anesthetics? What's the anesthetics of choice?
Yes. So again, as I mentioned, it depends on the type of the procedure and the duration of the procedure. We have got 2% prilocaine, which is 20 milligram per ml, high heavy prilocaine, which we normally use it for procedures like for 40 minutes to an hour. Even if for cystoscopies we do use it 2% prilocaine, and that is the choice. But as a part of the orthopedic procedure, if we literally quite recently started a LEAP protocol, which is the Leicester Enhanced protocol for the arthroplasties, where we use the 0.5% levobupivacaine without any opioids, and then there is a protocol to give the analgesia, dexamethasone, and those patients can be discharged on the same day after their knee replacement. This is what our protocol in our trust. But for a shorter procedures like 40 minutes to 60 minutes, 2% prilocaine heavy.
Okay. There is another question. Shahid Khan has a question regarding can we do minor gynecological surgeries as a day case surgery? What is your technique of choice?
I mean, if we can definitely do, as I mentioned in my slide, that gynecological procedure can be safely be done as a day case procedure, like Bartholin cyst removal, hysteroscopy, even laparoscopy for treatment of endometriosis can easily be done as a safe day case procedures. But what if you ask me my practice, I mean, I do most of the laparoscopies under iGel. It's been like probably 6-7 years. I haven't intubated any laparoscopic cholecystectomy since 2017. So I didn't intubate anybody. Because my argument was the position during the laparoscopic cholecystectomy is head up and rightward tilt. So that is in favor of you. So the patient doesn't have any regurgitation. But obviously you need to assess the patient according to their weight, height, according to their comorbidities. But normally iGels for my minor laparoscopic procedure, that is my technique of choice.
Well, thank you. There is another question by Dr. Nadir Adil. He just want to ask about the sir, pre-anesthesia assessment should be done as ASA scoring, but sir said about physical functional capacity, we decide either surgery will be done or not.
Yes.
I'm unable to understand the question. If you're getting something, you
I
can respond it.
uh, I don't know what he wants to ask, because that's what my main concern I want to say.
Sorry,
is
Nadir,
how
could you please unmute and ask your question? If you could come on the microphone. Okay, sir. You can continue.
Okay, so what I don't know what he wants to know, but you know, normally we go for ASA status, but as part of the pre-assessment and selecting a patient for the day case procedure, I said that you need to assess the patient by their physiological status, because if the patient has got diabetes, he has got ischemic heart disease, you can label him as a ASA 3, and you might say that, oh, this patient is not suitable for day case procedure. But if the patient is doing exercise every day, he goes to gym 3 times a week, and his diabetes is controlled, his hemoglobin A1C is very well controlled within normal limits, so then he can still be done as a day case procedure. So that's why that was my main aim, to say that you need to assess the patient in the pre-assessment by the physiological status rather than ASA status.
Thank you, Dr. Nabil, for such a nice and insightful talk. Um, we are really thankful for you,
No problem.
for you to spare your precious time and to give the talk.
Thank you very much
So,
for
if
giving me
it's
the opportunity to just come and just share my experience, which I have learned so far here.
Thank you, thanks a lot. Meanwhile, we have some other questions as well,
Yes.
but we have 3 minutes left behind. Okay, so Nadir Adil is saying that he has got the answer.
Okay.
So these are the comments actually, not the questions. Okay, thank you, sir. Thanks a lot. We'll see you.